Hello, please subscribe and like for our channel. Thanks very much.
Hello, welcome to this new short case tutorial. This short case tutorial is presented by the SchrDbb, and please, we're going to welcome you to subscribe for the channel for also be motivated to do for the other videos. So this short case states that a 28-year-old female presents with fever and the following urinalysis results. She presents with fever and the following urinalysis result. The urobilinogen is negative, the bilirubin is negative, the ketone is negative, ascorbic acid is negative, red blood cells is 15 cells per microliter, white blood cells is 100 cells per microliter. Microliter is the same as millimeter cube. Nitrite is positive. The protein is 30 mg per deciliter. The pH is 7. The specific gravity is 1.020. Now, they are asking you what abnormalities are shown. Before I'll answer the abnormalities shown, I'm just going to explain you the different elements of the urine dipstick. Actually, the equation is not actually urinalysis, but it is urine dipstick, to be more specific. Because you have to know that what urinalysis is mainly divided into two. Basically, we have urine dipstick and we have urine microscopy. We have even other biochemical analysis of the urine as seen under the urine analysis. Basically, so when you say urinalysis is very broad. So urinalysis is having three major parts. We have dipstick, we have microscopy, and we have other biochemical urine analysis. Are you understanding? Now, in this case, this is the urine dipstick. Okay, now I will take now the first element of the urine dipstick here is the urobilinogen. So the urobilinogen, how does it help you? Now the urobilinogen and the bilirubin work together. It helps you to understand if there is high level of bilirubin or not. Now you need to know that when talking about jaundice, you speak about pre-hepatic, hepatic, and post-hepatic jaundice. Now in the case of pre-hepatic jaundice, you're going to have more of unconjugated bilirubin, while in the case of post-hepatic jaundice, you're going to have more of conjugated bilirubin. Now the question is, with just the urine dipstick, are you capable of knowing if the jaundice is as a result of a high level of conjugated bilirubin or as a result of high level of unconjugated bilirubin? The answer is yes. It is based on the urobilinogen and the bilirubin. Is it clear? Now we need to know that in case when the bilirubin is high, it means that there is more of conjugated hyperbilirubinemia. Is it clear? Now the answer is why. The answer is because when you have a high conjugated hyperbilirubinemia, it is mostly as a result of a post-hepatic jaundice, meaning that the bilirubin is not going into the gastrointestinal tract. And since the bilirubin is not going into the gastrointestinal tract, all the conjugated bilirubin is going to be the loss inside the urine. So in the case of a hyper-conjugated bilirubin, you are going to have high level of bilirubin in urine, and since that conjugated bilirubin is more soluble in water, that's why conjugated bilirubin is going to be much more in urine. It's going to be secreted in urine. And in patient that has high conjugated bilirubin, there is not going to be any urobilinogen in urine. Are you understanding? Now, in the case where you have a patient, for this. So now the next thing after that, so when you have the conjugated bilirubin, I'm sorry for the first thing that happened. Now in a case where you have high urobilinogen or you have a positive urobilinogen in the urine dipstick, what does it mean? It means that you're going to instead have a high level of unconjugated bilirubin, and the reason is because Unconjugated bilirubin is converted to conjugated bilirubin and is going to be lost at the level of gastrointestinal tract, while in the case where it is not a post-hepatic jaundice, is it clear? It's going to be lost at the level of the gastrointestinal tract, and since it's lost at the level of gastrointestinal tract, that conjugated bilirubin in the gastrointestinal tract is going to be converted now to urobilinogen, and the urobilinogen is going to be reabsorbed now into the systemic circulation and it's going to be dissolving in water. That's why it is going to be present in urine. In the case where you have unconjugated hyperbilirubinemia, since though there is high level of bilirubin in blood, there is still not bilirubin present in the urine district, just because unconjugated bilirubin is not soluble in water. Are you understanding? So those are the different elements. So as a point of summary, urobilinogen, when it's present, is a marker of high level of unconjugated bilirubin. Now, bilirubin, when it's present, it's a marker of high level of conjugated bilirubin. Now, if you see both, it means that both of them are high. Are you understanding? Now, the next point is ketone. Now, ketone, at least of 2+, can tell you of a diabetic ketoacidosis. Is it clear? So you have a diabetic ketoacidosis when you have high level of, when you have ketone, at least 2+ of ketone inside a urine dipstick. When you have at least 2+ of ketone inside the urine dipstick, it tells you that there is a diabetic ketoacidosis. Is it clear? The ketose of the ketosis portion of the diabetic ketoacidosis is with that ketone. Is it clear? So, and now, generally, when you have ketones at the level of urine, it tells you that a patient is not secreting insulin. Is it clear? And when a patient is not secreting insulin, it's either the patient has type 1 diabetes or the patient has a very late phase of a type 2 diabetes. Now, the ascorbic acid is just vitamin C, and if you have taken vitamin C, you are going to have high level of ascorbic acid. So it's not going to be high level of interest. Is it clear? But as this ascorbic acid can also tell you, is much more going to be in favor with urine stones. Is it clear? Because in cases where you have high ascorbic acid, a high ascorbic acid in urine promotes the formation of urine stones. So if you think of a diagnosis of urinary stone and you visualize ascorbic acid, can go towards your urinary stone. The red blood cells. Now you need to know that what? On the urine dipstick, there is a portion. If you have a urine dipstick in front of you, just take it and try to visualize it. Try to visualize the interpretation. On the urine dipstick, you have blood. Is it clear? That hematuria. Now you have blood divided into two portions. You have the part that speak about hemoglobin, and there is a part that speak about just hematuria. Now, if you go on urine dipstick, you see a certain portion that speak about hemolyzed blood and non-hemolyzed blood. Is it clear? When you have hemolyzed blood, it is much more of hemoglobin that they are speaking. When there is non-hemolyzed blood, it is much more of the red blood cell, the gross red blood cell that they are speaking. Because you have to know that there is a difference between hemoglobinuria and a true hematuria. A true hematuria is a presence of red blood cells in urine, while hemoglobinuria is a presence of hemoglobin in urine. Is it clear? Now, the next point is the white blood cells. Normally, the white blood cell has to be less than 5 white blood cells per high power field. Is it clear? But now here is already up to 100 cells per microliter. And also, the red blood cell is 15 cells. Is it clear? Per microliter. It means that there is also a urine microscopy that has been done here. On the dipstick, you are going to instead have a leukocyte esterase that is going to tell you if there is a presence of white blood cells or not. But when they are saying that white blood cells is 100 cells, it means that they have done the microscopy to visualize. It's not more the dipstick. It is both the dipstick and. Now, the next point after that, so we have now white blood cells. We've spoken about the white blood cells. Now, with the next thing and the red blood cell, so since the red blood cell and the white blood cell have been given in the question, means that they have done a microscopy. For the red blood cell to analyze it on the urine dipstick is hematuria. There's a portion of non-hemolyzed blood and there is hemolyzed blood. And for the white blood cell, to identify white blood cells on urine dipstick, the leukocyte esterase enzyme that you're going to visualize it. It's going to be 1+, 2+, or 3+ and all that. Is it clear? Now, for the nitrite, now we need to know that nitrite helps you to know if there is a presence of certain nitrite positive microorganism. When you see there is a positive nitrite, it means that there are nitrite positive microorganisms, and there are the major nitrite positive microorganisms are the microorganisms from the Enterobacteriaceae family. Is it clear? And among those organisms, you have the Escherichia coli, you have Proteus, and you have Klebsiella. Is it clear? So those are the microorganisms that are nitrite positive, and they are going to be showing that on the urine dipstick. Now, for the protein, generally you have to know that what when you have 0, it means that there is no protein, no proteinuria. Now, 1+, but there's after 0 there is trace. Trace is when you are between 0 and 30 mg per deciliter. Now, 1+ is at the level of 50 mg per deciliter. 2+ at the level of 100 mg per deciliter. 3+ at the level of 300 mg per deciliter. And then the last one is 4+, which is at the level of 1000 mg per deciliter. Is it clear? Now, we need to know that what proteinuria can be divided into 3. Is it clear? We have proteinuria that can be divided into 3. We have the first one, which is a nephrotic range proteinuria, meaning that you have a urine dipstick of at least 3+, and 4+. It means that the urine that is being lost is more than 3 grams per deciliter in 24 hours. That's a nephrotic range proteinuria. Now, the next thing after the nephrotic range proteinuria, we have now what is called the glomerular range proteinuria. The glomerular range proteinuria is when you have 2+ and 3+. Is it clear? When you have 2+ and 3+, it's a glomerular range proteinuria. Is it clear? And in this case, you lost, when you do analysis of urine for 24 hours, is going to be between 1 gram to 3 grams per deciliter per day. That is a glomerular range proteinuria. And then the last one is a non-glomerular proteinuria. It can be forming from the tubules. Is it clear? And then non-glomerular proteinuria is having either trace or is having a 1+ proteinuria. Is it clear? And in this case of non-glomerular proteinuria, you are going to have a urine protein content in 24 hours, which is of less than 1 gram per deciliter. Is it clear? And now the next one is the pH. The pH can favor the production of certain urine stone. Like acidic pH is going to be much more in the cases of uric acid stones, in the cases of when you have uric acid stones, when you have SchrDbb stones. So when you have uric acid stones, they're going to be more acidic, they're going to more develop in acidic pH. While basic pH are going to much more develop now calcic stones and also SchrDbb stones. Like that's the SchrDbb stones and magnesium sulfate stones. Is it clear? They are going to develop SchrDbb stones. Is it clear? Now, based on the pH, now you can develop now the dissolution mechanism that I'm going to speak about here. Now, the next thing, the specific gravity. The specific gravity can tell you that there is a high osmolarity of the urine or a low osmolarity of a urine. Example: if somebody is dehydrated, the urine is going to have a high specific gravity. Meaning that what? Meaning that the urine is going to be much more concentrated. So it can also be helping you to know if somebody is dehydrated or not. Is it clear? So that specific gravity tells you the level of the osmolarity of the urine. So now let's go now to the question. So the question is, what are the abnormalities shown? So the abnormalities shown here, you have 1, hematuria, 2, leukocyturia, 3, nitrite positive. Is it clear? So 1, hematuria, 2, leukocyturia, 3, nitrite positive, 4, you have a proteinuria. So those are the 4 abnormalities shown. Now the question that you are going to ask me is, why is there a proteinuria now in this case? There is a proteinuria in this case because every time that you have
hematuria. Hematuria can result to a proteinuria. This proteinuria is not a glomerular range proteinuria because 30 milligram is either trace or 1+. Is it clear? When you have now instead a glomerular range proteinuria, it is going to be instead more than 30 milligram. That's going to be at the level of 100 milligram per deciliter. Is it clear? I hope you're understanding where I'm trying to move to. So in this case, you have white blood cells. Is it clear? So you have white blood cells, you have nitrite positive, you have hematuria. And that hematuria, because you have to know that also hematuria is divided into two. You have frank true hematuria is divided into two. I'm not talking about hemoglobinuria. True hematuria, that is the presence of red blood cells, is divided into two. It's divided into nephrologic hematuria and urologic hematuria. Is it clear? Nephrologic hematuria means that the red blood cells is coming from the kidney, and in that case the red blood cells are going to having a Mickey Mouse appearance. Is it clear? They are going to be dysmorphic. Is it clear? But in the case of a urologic hematuria, the red blood cells are going to be the normal biconcave shape. Is it clear? So in this case, since there is white blood cell, there is nitrite positive, there is red blood cells. The red blood cells, that hematuria, I think that it is much more of a urologic hematuria. The white blood cell is there to tell you that there is a urinary tract infection. The nitrite positive is going to tell you that there is the causative organism are the Enterobacteriaceae family. Is it clear? And then the proteins is just an artifact produced by the red blood cells. Is it clear? So what is the abnormality shown? I've already said hematuria, leukocyturia, nitrite positive, proteinuria. The next one is what is the likely diagnosis? So the answer is urinary tract infection. That is your answer. Is it clear? So urinary tract infection. So you can also add among the urinary tract infection, since this woman is having, when they're asking you for the diagnosis, always try to go back to the clinical presentation. Is it clear? In this case, you go back again to the clinical presentation. Say the 28-year-old present with fever. It means that it's not just urinary tract infection, but it is upper urinary tract infection. And when we speak about upper urinary tract infection, we speak about acute pyelonephritis. So the answer here is acute pyelonephritis to be more specific. Is it clear? So every time you hear about the likely diagnosis, go back to your clinical presentation, because lower urinary tract infection is not going to have any fever. It's only upper urinary tract infection, including acute pyelonephritis. Now the next question is, name the 3 likely causative germs. The 3 likely causative germs here are, you go back to the nitrite positive. That nitrite positive tells you the Enterobacteriaceae. So it's Escherichia coli, Klebsiella, and Proteus. Is it clear? The next thing is, what are the modalities of the treatment? The modalities of treatment are the means of management. So you do general means of management, and then you do the medical means of management. Among the general means of management, ask for fluid rehydration. The patient has to take enough water in order to urinate, to push out, to clear the urine, the urinary system. And then the next means of management is medical means or pharmacological means of management, where you give antibiotic. So then these are what you have to know. Now the next question is, which question must you ask this patient before performing your test? So when performing the test of the urine analysis, another reason why this woman may have the presence of those red blood cells is because the patient is having her menses. So you ask again another question, is this woman on menses? And that is the answer. Is it clear? So the red blood cell can still be present either as sort of a urologic hematuria, meaning that what? The hematuria, the red blood cells are coming from the urine tubes, the urinary tract, and not from the kidney. Is it clear? They are coming down from the urinary tract as a result of the infection. If that hematuria is not coming from the urinary tract, it may be coming from the blood from the menses. Since it's a female, she is in active or reproductive age. Is it clear? So you have to ask if she is on her menses. So those are the 5 questions. So from here, say thanks for your kind attention.
Hello, purchase your book, medical book, health science book, physics book, computer science book, all from us on 652-659429. And please don't forget to like and subscribe for our 2 channels, Science Video Makers and SchrDbb. Let me say the number again, 6569 9429. That is the place where you're going to have all these books. As you can see, we have the computer science book, which is shown in this image. You can see this is all the example of the computer science book all inside. You have all this. We have the medical book for the first year, second year, third year, all available with all the explanation and questions. We have the physical examination book with all the step-by-step physical examination. This is the workbook for medical third year. The workbook for medical third year. This is the first year workbook. This is the second year workbook. As you can see, this is the second year textbook. All this we have on the no contact 652 659429. Thanks very much.